Hi everyone, welcome back to the channel. Today we're going to walk through one of the most important parts of the physical examination, the neurological exam, often abbreviated as NE. It is performed whenever we suspect involvement of the nervous system. This includes cases of altered consciousness, headache, seizures, trauma, stroke, infections, or when patients present with weakness, numbness, or coordination problems. The neurological exam helps us identify abnormalities, localize where a lesion might be, and track how a disease is progressing over time. Let's begin with the Glasgow Coma Scale, or GCS. This is the standard tool we use to assess a patient's level of consciousness. The GCS has three components: eye-opening, verbal response, and motor response. Each category is scored separately, and then the scores are added together for a total ranging from 3 to 15. For eye-opening, 4 points if the patient opens their eyes spontaneously, 3 if they open them in response to sound, 2 if it takes pressure or pain, and 1 if there's no eye opening at all. For verbal response, 5 points if the patient is oriented and speaks normally, 4 if they're confused, 3 if they use inappropriate words, 2 if they make only incomprehensible sounds, and 1 if there's no verbal response. And finally, for motor response, 6 points if the patient obeys commands, 5 if they localize pain, 4 if they withdraw from pain, 3 if they show abnormal flexion, also called decorticate posturing, 2 if they show abnormal extension, also called decubitate posturing, and 1 if there's no motor response. When you add these scores together, you can classify the severity of brain injury. Mild if the total score is 13 to 15, moderate if it's 9 to 12, and severe if it's 3 to 8, often requiring endotracheal intubation for airway protection. Next, let's talk about cognitive test, which examines high cortical function. An easy way to remember the key components is with the acronym JOMAC. The J stands for judgment. We can test this by asking problem-solving or situational questions, like, what would you do if your house is on fire? A logical answer like, I would get out of the house and call the fire department, suggests intact judgment. On the other hand, an unrealistic or unsafe response could indicate impaired judgment. The O stands for orientation. Here we check whether the patient is oriented to time, place, and person. For example, we might ask, what is today's date? Where are you right now? Who am I? The M stands for memory. We usually test this in 3 parts. Immediate memory, such as repeating a series of numbers, short-term memory, like recalling 3 objects after a few minutes, and long-term memory, such as asking about historical events or personal background. The A is for abstraction, the capacity to reason beyond the literal and to generalize or interpret similarities, metaphors, and patterns. One way to test this is by asking about the meaning of a common proverb. For example, what does the saying, "the early bird catches the worm," mean? Another approach is to ask the patient to identify similarities, like, how are an apple and an orange alike? The key is that we're checking whether the patient can move beyond concrete facts and demonstrate higher-level reasoning. Finally, the C is for calculation. A simple way to test this is to ask the patient to subtract serial sevens from 100. Serial subtraction not only evaluates calculation skills, but it also gives us important information about the patient's concentration and attention span. Altogether, JOMAC gives us a quick and structured way to evaluate higher cortical functions and detect early cognitive impairment. Next up, let's go through the cranial nerves. There are 12 in total, and we'll test them in order. The first cranial nerve, or the olfactory nerve, controls the sense of smell. To test it, ask the patient to close their eyes and occlude one nostril. Then present a familiar scent like coffee beans and see if they can identify it. For the second cranial nerve, or the optic nerve, we test 3 things. Visual acuity, which is how clearly a person can see, is tested with a Snellen chart. Have the patient stand 6 meters away from a Snellen chart and then ask them to cover one eye and read the smallest line of letters they can see. Then repeat with the other eye. The second test involves a visual field, which is the extent of a person's peripheral vision. To perform this test, sit or stand about 1 meter in front of the patient at eye level and ask them to cover one eye while you cover your opposite eye. Tell them to look straight at your open eye and keep their gaze fixed there. Stretch your arm halfway between you and the patient. Then wiggle your fingers in one quadrant at a time and ask the patient to say "now" as soon as they see the movement. Compare their response with your own visual field, then repeat on the other side. And the third test is a fundoscopic exam. Using an ophthalmoscope, Follow the red reflex to inspect the optic disc, retinal vessels, and macula. Look for papilledema, which may indicate raised intracranial pressure, optic atrophy, suggesting optic nerve damage, and retinal hemorrhages or exudates, which can reflect vascular or systemic disease. Next, we test the 3rd, 4th, and 6th cranial nerves together since they control eye movement. Start by checking pupil size and reactivity to light. Normal pupil size ranges from about 2 to 4 millimeters in bright light. Pupils should be equal in size and round, with no difference greater than 1 millimeter between the two eyes. Unequal or abnormally large or small pupils may indicate Horner's syndrome, third nerve palsy, or drug effects. Next, look for ptosis or drooping of the eyelid, which could indicate lesions of the third nerve, Horner's syndrome, or myasthenia gravis, where neuromuscular transmission is impaired. Then, assess extraocular movements by asking the patient to follow your finger in an H pattern without moving their head. Watch for nystagmus, diplopia, or restricted movement. For the 5th cranial nerve or the trigeminal nerve, check facial sensation in the forehead, cheek, and jaw using light touch or a pin. Then, test the motor function by palpating the masseter and temporalis muscles as the patient clenches their teeth. For the 7th cranial nerve or facial nerve, ask the patient to perform different facial movements. Raise their eyebrows, close their eyes tightly, puff out their cheeks, and smile. Look for asymmetry or weakness. The 8th cranial nerve or the vestibulocochlear nerve controls our hearing. You can do a finger rub test near each ear and ask the patient to identify it. If hearing loss is suspected, you can go one step further to perform the Weber and Rinus test using a tuning fork. In the Weber test, place a vibrating tuning fork on the center of the forehead. The sounds should be heard equally on both sides. The sound is heard louder in the affected ear if it's a conductive hearing loss. In the Rin test, place the tuning fork first on the mastoid, which tests bone conduction, then beside the ear canal, which tests air conduction. Normally, sound is louder through air than bone. If bone is louder, that means conductive hearing loss. If both are reduced but air still louder, that means sensorineural hearing loss. For the 9th and 10th cranial nerve, the glossopharyngeal and vagus nerves, ask the patient to open their mouth and say ah. Watch the palate and uvula rise. It should elevate symmetrically. For the 11th cranial nerve or the accessory nerve, check the sternocleidomastoid by asking the patient to turn their head against resistance, and the trapezius by asking them to shrug their shoulders while you press down. For the 12th cranial nerve or the hypoglossal nerve, ask the patient to stick out their tongue. It should protrude in the midline. Deviation to one side suggests weakness on that side. After testing the cranial nerves individually, we can also check some important reflexes. Each reflex involves a sensory input carried by one nerve and a motor output carried by another. The first is the pupillary light reflex. The input comes from cranial nerve 2, the optic nerve, which detects the light. The output comes from cranial nerve 3, the oculomotor nerve, which constricts the pupil. To test this reflex, shine a light into one eye. The pupil you shine into should constrict, which we call the direct response. The indirect light reflex is the simultaneous constriction of the opposite pupil. Next is the corneal reflex. The input comes from cranial nerve 5, the trigeminal nerve, which senses the light touch on the cornea. The output comes from cranial nerve 7, the facial nerve, which makes the eyes blink. To test this reflex, gently touch the cornea with a wisp of cotton. A normal response is that both eyes blink involuntarily. Finally, we have the gag reflex. The input comes from cranial nerve 9, which senses the touch on the back of the throat. The output comes from cranial nerve 10, the vagus nerve, which lifts the soft palate and produces the gag. To test this reflex, use a tongue depressor or a cotton swab to gently touch the back of the throat near the tonsil area. A normal response is a gag together with symmetrical elevation of the palate. Let's move on to motor function, which consists of several parts. We'll begin with muscle tone, which is the natural, continuous, and passive resistance of a muscle when it is stretched. To test muscle tone, ask the patient to relax completely. Then, passively move their joints. For example, flex and extend the elbow, rotate the wrist, or move the ankle. Normally, you should feel only minimal resistance as the limb moves through its range of motion. If the limb feels unusually floppy and offers very little resistance, that indicates hypotonia, which can be associated with lower motor neuron lesions. On the other hand, if the muscle feels stiff or rigid throughout the entire range of motion, this suggests hypertonia. Depending on the pattern, it could be spasticity, which is velocity-dependent and often seen in upper motor neuron lesions, or rigidity, which is uniform and may be seen in conditions like Parkinson's disease. Next, let's assess muscle power. For the upper limbs, to test the deltoid muscle supplied by C5, ask the patient to lift their arm sideways to shoulder level while you apply gentle downward pressure. To test the biceps supplied by C5 and C6, ask the patient to bend the elbow while you resist the movement. To test the triceps supplied by C7, ask the patient to straighten the elbow against your resistance. To test the wrist extensors supplied by C6, ask the patient to lift the back of the hand upward while you push down. To test the wrist flexors supplied by C7, ask the patient to bend the wrist upward against resistance. To test the hand grip supplied mainly by C8, ask the patient to squeeze your fingers as tightly as possible and resist you pulling away. To test finger abduction supplied by T1, ask the patient to spread their fingers apart while you try to push them together. To test thumb opposition supplied by C8 and T1, ask the patient to bring the thumb across to touch the little finger while you apply gentle resistance. Next, move on to the lower limbs. To test the hip flexors supplied by L2 and L3, ask the patient to lift the thigh off the bed while you press down on the front of the thigh. To test the knee extensors supplied by L3 and L4, ask the patient to straighten the knee against your resistance while you support it underneath. To test the knee flexors supplied by L5 and S1, ask the patient to bend the knee while you resist the movement at the ankle. To test the ankle dorsiflexors supplied by L4, ask the patient to lift the foot upward toward the shin while you push down on the top of the foot. To test the ankle plantar flexors supplied by S1 and S2, ask the patient to point the foot downward while you resist the movement at the sole. Muscle power can be graded on a 5-point scale. Grade 0 means there is no muscle contraction at all. Grade 1 means there is a slight flicker of contraction, but no actual movement of the joint. Grade 2 means the patient can move the limb only when gravity is eliminated. Grade 3 means the patient can move the limb against gravity, but not against any added resistance from the examiner. Grade 4 means the patient can move against some resistance, but the strength is still weaker than normal. And Grade 5 means normal muscle power, the patient can move against full resistance, and strength is equal on both sides. Next, let's talk about deep tendon reflex, often called DTR. A deep tendon reflex is an involuntary muscle contraction that occurs when we tap on a tendon with a reflex hammer. The tap stretches the muscle spindle, which sends a signal through the sensory neuron, then through the spinal cord and back out through the motor neuron to cause a contraction. There are 5 commonly tested deep tendon reflexes. For the biceps reflex, tap on the biceps tendon in the antecubital fossa while the patient's arm is relaxed and partially flexed. A normal response is contraction of the biceps muscle and flexion of the elbow. This reflex tests the C5 and C6 spinal roots and the musculocutaneous nerve. For the brachioradialis reflex, tap on the brachioradialis tendon, about 5 centimeters above the wrist. The normal response is flexion and supination of the forearm. This reflex also tests C5 and C6. For the triceps reflex, tap on the triceps tendon just above the elbow while the arm is flexed and relaxed. A normal response is contraction of the triceps and extension of the elbow. This checks the C7 and C8 spinal nerves. For the patellar reflex or knee jerk, tap on the patellar tendon just below the kneecap while the patient is sitting with legs dangling. The normal response is contraction of the quadriceps and extension of the knee. This tests the L2 to L4 spinal roots and the femoral nerve. For the Achilles reflex, tap on the Achilles tendon while the patient's foot is slightly dorsiflexed. The normal response is plantar flexion of the foot. This reflex tests S1 and S2 through the tibial nerve. We grade the reflexes on a scale of 0 to 4. The normal deep tendon reflexes is 2+. A grade of 0 means the reflex is absent, and 1+ means it is present but hypoactive. These usually suggest a lower motor neuron lesion or peripheral neuropathy. On the other hand, 3+ means the reflex is brisk, and 4+ means it is very brisk and may even produce clonus. These findings point toward an upper motor neuron lesion. Now let's move on to pathological reflexes. These are abnormal reflexes that usually appear when there is an upper motor neuron lesion. The most important one is the Babinski sign. To test this, use the end of a reflex hammer or a blunt object and stroke the lateral border of the sole of the foot, moving upward and across the ball of the foot. A normal response is plantar flexion. A pathological response is dorsiflexion of the big toe. Another abnormal reflex is the Hoffman's sign, which is essentially the upper limb equivalent of the Babinski. To test this, flick the nail of the middle or ring finger downward. In a positive response, the thumb or index finger flexes involuntarily. This also suggests upper motor neuron lesion. Next, let's talk about coordination, which primarily tests cerebellar function, which is responsible for smooth, accurate, and coordinated movements. There are several standard tests we use. First is the finger-nose-finger test. Ask the patient to touch their own nose, then your finger, and repeat this back and forth. Move your finger around to different positions. If the patient overshoots or misses the target, we call that dysmetria, which suggests cerebellar dysfunction. Second is the heel-knee-shin test. Ask the patient while lying down to place the heel of one foot on the opposite knee, then slide it down along the shin to the ankle. Normally, the movement is straight and controlled. Wobbling or sliding off the shin indicates impaired coordination. Finally, there is the rapid alternating movements. Ask the patient to rapidly pronate and supinate their hands on their thighs, or to tap the thumb to each finger quickly. Normally, the movements are fast and rhythmic. If the movements are slow, irregular, or clumsy, we call this dysdiadochokinesia, another sign of cerebellar disease. The final part of the motor exam is to observe the patient's gait. Watching how a patient walks can reveal a lot about motor function, coordination, balance, and even sensory input. First, assess the casual gait. Ask the patient to walk across the room at a normal pace, then turn and walk back. Observe their posture, stride length, arm swing, and whether the steps are smooth and symmetrical. Abnormal findings might include a shuffling gait in Parkinson's disease, a wide-based gait in cerebellar ataxia, or foot drop causing a high-stepping gait. Next, test the tandem gait. Ask the patient to walk heel to toe in a straight line as if walking on a tightrope. This is more challenging and can reveal subtle balance or coordination problems. Now let's move on to sensory function, which we usually divide into two parts, primary sensation and cortical sensation. First, let's look at primary sensation, which tests the basic sensory pathways. Light touch can be tested by gently brushing the skin with cotton or your fingertip, and asking the patient to say yes whenever they feel it. Pinprick is tested using a disposable pin or neurotip, lightly touching the skin and asking if the sensation feels sharp or dull. Vibration sense is tested with a 128 Hz tuning fork placed on bony prominences. The patient should be able to feel the vibration and tell you when it stops. Proprioception can be assessed by holding the sides of a finger or toe and moving it up or down with the patient's eyes closed. Ask them to identify the direction of movement. An important related test is the Romberg test. Ask the patient to stand with their feet together and eyes closed. If they lose balance when the eyes are closed but were stable with eyes open, this indicates impaired proprioception. Next, we assess cortical sensation, which relies on both intact primary sensation and higher cortical processing. These tests include two-point discrimination, where you touch the skin with 1 or 2 points and ask if the patient feels 1 or 2. Stereognosis, where you place a familiar object like a key or coin in the patient's hand and ask them to identify it with eyes closed. Graphesthesia, where you trace a number or letter on the patient's palm and ask them to recognize it. And that wraps up our overview of the neurological exam. We started with the Glasgow Coma scale to assess consciousness, then moved on to cognitive tests using the JOMAC framework. After that, we tested the cranial nerves, motor function including tone, power, reflexes, and coordination, and finally the sensory system, covering both primary and cortical sensations. By following this structured approach, you'll be able to perform a thorough neurological exam, identify abnormalities, and localize lesions with much more confidence. Thanks for watching, and I'll see you in the next one.